Thank you, first of all, for the organization for inviting me to give this talk. Like you mentioned, I'm one of the GI medical oncologists currently at Moffitt Cancer Center in Tampa, Florida. And I specialize seeing GI tumors, and one of the diseases that I do see is pancreatic cancer. And the topic that was given to me for the next 30 minutes is to discuss the current management of advanced pancreatic cancer. So just briefly, the outline of my talk, I'll just briefly talk about the epidemiology. And I will go over the current first-line treatment standard that's currently done in the U.S. I know depending on where it's coming from, you know, sorry, the slides are gone. Sorry. So I guess so I guess depending on the region or the country you live in, the first-line standard treatment may differ. But in U.S., I'll be just sort of going over the first-line treatment, what's happening in U.S. Then I'll be going over the second-line treatment. Last but not least, I'll be talking about some of the novel treatments or novel therapies, including immunotherapy, that's currently going on in U.S. as well. So just brief, epidemiology-wise, in 2015, this also applies to 2016 as well. At least in the U.S., there are about 50,000 new cases, and unfortunately, most of them die because of the disease. And unfortunately, in the U.S., due to the multiple factor, the incidence of pancreatic cancer has been rising. So if you look at the estimated new cases of pancreatic cancer, it is actually only 3% in terms of the incidence of the cancer. So it's not as high as prostate or colon or lung cancer. However, if you look at the death, unfortunately, most of the patients will eventually succumb to the disease. So this is the reason why we need a lot more work to be done in pancreatic cancer so that we could improve on that status. So most of the patients are found, unfortunately, in metastatic stage. About more than 50% when they present to your clinic will have advanced disease, and their 5-year survival is less than 2%. If you're fortunate enough to be found at early stage, that only occurs probably, I think 8% is a little bit low, probably around 15%, I would say, in my practice, are found early enough that you could go for surgery. Even if you are fortunate enough to go for surgery, the 5-year survival is only 22% if you're node negative. If you're node positive, the 5-year survival is less than 10%, telling us that this disease is very aggressive. So if you were diagnosed with pancreatic cancer, stage 4 pancreatic cancer in 1995, then we had very little choice at that time. At that time, the only option we had was 5-FU bolus, 5-FU infusion, or some kind of combination of 5-FU bolus and 5-FU, or hospice. That was it. There were no other options available if you were diagnosed with stage 4 pancreatic cancer in 1995. Then in 1997, the first drug that got approved in the US, at least by the FDA, is a drug called gemcitabine. This was done based on a small study actually comparing against 5-FU, and it was actually based on the clinical benefit, not on overall survival or time to progression, but based on overall clinical benefit. And as you could see from this slide, that the clinical benefit favored the arm of gemcitabine. Even though it was not the primary endpoint, the time to tumor progression and survival, median overall survival also favored the arm of Gemzar as well. So based on the clinical benefit, this drug got approved. Now, in 2016, none of the drugs would get approved just based on the clinical benefit. So once the Gemzar was approved, the next step was to add another chemotherapy on top of Gemzar to see if it's better than Gemzar. So in this slide, I have listed several of phase 3 studies which combine Gemzar plus drug X against Gemzar alone. And unfortunately, none of the trials are positive. The overall survival in both arms are very similar, therefore all negative studies. So if the combination therapies were all negative, then what we tried to do was do a meta-analysis. We tried to lump all the trials together to see if there's any potential benefit of certain chemotherapies. Even though this is not considered standard, gold standard, once they did the meta-analysis, there are two types of chemo that showed maybe a little bit of benefit combining with Gemzar versus Gemzar alone. One is combining the platinum therapies such as cisplatin and oxaliplatin to Gemzar, shows that it was maybe slightly superior to Gemzar alone. But as you can see, the hazard ratio is only 0.85, which really translates into 15%, 1.5 relative risk reduction. And other combination is 5FU. And in that study, the hazard ratio is 0.90. So overall, based on the meta-analysis, maybe the combination of Gemzar plus platinum or Gemzar plus 5FU may be a little bit better than Gemzar alone. However, once again, this was just based on meta-analysis. Then the next step is what? Is targeted agents, right? In 2000, there were a lot of targeted agents that came about. So if it works in other disease, it must work in pancreatic cancer as well. Well, they did a lot of studies on that as well. They tried the drug that's targeting multiple pathways, including VEGF, EGFR, and TKIs as well. And only trial that actually became positive, as you're aware of, is erlotinib. Okay, is oral TKI that blocks the EGFR pathway. But the problem with that drug is that the benefit was 2 weeks. Okay, so even though it was significant by p-value, the benefit of median overall survival is only 2 weeks. Therefore, despite the significant difference in overall survival, the median absolute improvement of 0.33 months or 2 weeks may be neither clinically meaningful nor cost effective. Therefore, this drug, even though it's positive results, and it is approved in the US, even though none of us really use them, it's not approved in other countries because of the cost effectiveness. The other issue with erlotinib is that we know the toxicity is something of an issue, such as rash and diarrhea. And also, we have no predictive biomarker. It is interesting to see how this drug works because about 90% of pancreatic cancer patients are KRAS mutant. So it is unclear how this drug works, but at least based on the data, we don't have any predictive marker that will tell us who will respond to this drug. So now we have better results seen with other regimens. So while that was going on in US, in Europe, they were taking a different approach. They liked this combination called the FOLFIRINOX, which is a combination of 5FU, oxaliplatin, and irinotecan. So the group in France did a randomized large phase 3 study in patients with stage 4 pancreatic cancer, randomizing to FOLFIRINOX versus Gemzar alone. And the primary endpoint was overall survival. So here are the inclusion criteria. There are a couple of things that I want to point out is that most of the patients were very good performance status of 0 to 1, no prior cytotoxic chemotherapy, and no prior abdominal radiotherapy. And they must have had an adequate liver function test as well. And what they found was that by combining the FOLFIRINOX regimen to Gemzar, the FOLFIRINOX was much superior to Gemzar alone. The overall survival was 6.8 months with Gemzar compared to 11.1 months of FOLFIRINOX. So close to 3 to 4 months overall survival benefit by giving this tough regimen. And other endpoint that looked at the PFS was superior by close to 3 months. And the response rate is probably one of the highest we've seen in first line with 32% response rate for FOLFIRINOX. The 1-year survival was close to 50%. So half the patients who get FOLFIRINOX will live beyond 1 year, compared to Gemzar, which is only 20%. But what's the problem with this drug is that this drug is very toxic. Personally, I've given this drug as well in my practice many times, but heme toxicity, including neutropenia, febrile neutropenia, is real. Therefore, a lot of patients will get support with GCSF. And if you look at the fatigue, vomiting, diarrhea, it's worse with the FOLFIRINOX arm as well. So that's the concern when you use this combination in patients with advanced pancreatic cancer. So some of the points if you look at the trial of the FOLFIRINOX, some of the points that you have to consider is that a lot of patients in the study had tumor in the body and the tail of the pancreas. But we know that in real life, a lot of patients we see have tumor in the head of the pancreas, and they typically have a stentin, which can complicate the chemotherapy. And they're all very good performance status, And one of the main issues with this study is that this was only one country study. This was only done in France, okay? Which, if you did a multi-country study, the endpoint may vary or it may change, okay? So the problem with the FOLFIRINOX is that because it's a very toxic drug, is this the right backbone to use for further studies? Can you add another targeted agent on top of FOLFIRINOX to do a better trial? But is that possible because of the toxicity? So in real life, because of the potential toxicity, we sort of modify the FOLFIRINOX. In US, typically what we do is that we drop the 5-FU bolus and we decrease the irinotecan. So the question is that compromising the efficacy? Nobody knows. But currently we're doing that just to make this drug more palatable in certain patients. So while that was going on in France and Europe, in the United States, we took another approach and tried this new drug called Abraxane or paclitaxel. So in US, at about the same time, there was a randomized phase 3 study conducted in patients with advanced pancreatic cancer, randomizing to Gemzar alone or Gemzar plus Abraxane or paclitaxel. And the primary endpoint was similar to the other study, was overall survival. And this trial was also positive as well. Okay, so by adding nab-paclitaxel or Abraxane to Gemzar, there was an improvement in overall survival by close to 2 months, which was very significant by p-value with hazard ratio of 0.72. So the Gemzar arm was about 6.7 months, which is comparable to historical number. And by adding Abraxane, it went up to 8.5 months. Okay, showing that this drug was at a benefit, and therefore, based on this study in U.S., the Abraxane got approved in usage in first-line setting in combination with Gemzar. So, how about the other endpoints? The one-year survival was 35% in the combination. There was an improvement in PFS as well by close to 2 months. Okay. And the treatment duration, as expected, was much longer in the combination arm compared to Gemzar alone. Okay, so most of the endpoints were positive with the combination as well. So if you look at the subset analysis, it doesn't matter which subset you fell under. It seems like you benefited from adding Abraxane to Gemzar. Only thing I want to point out is the KPS of 7 to 80. In this study, they allowed patients with lower performance status. Okay, and even the patient with KPS 70 to 80, which is ECOG of 2 maybe, they still benefit from the combination. So one of the most common questions that I get is that patient with poor performance status, should I add Abraxane on top of Gemzar? And based on the data we have and based on the impact study here, they do benefit from the combination. So that's something to be taken aware of. So, one thing as a fellow and as a trainee that I was taught is never to compare study to study, right? Because we don't want to compare apples to oranges, but in this case, we sort of have to. So I put the side by side, the combination, the efficacy between FOLFIRINOX and nab-paclitaxel and Gemzar. And as you could see, if you look at the toxicity profile, at least the FOLFIRINOX seems to have a little bit more higher toxicity profile, including febrile neutropenia, and including more fatigue, and including more vomiting and diarrhea. Okay. Now, obviously, if you look at the response rate in PFS and overall survival, they do vary slightly. But once again, we're comparing apples and oranges. One thing that I want to point out in real life is the neuropathy. Both of the combination causes neuropathy. We know that with FOLFIRINOX with oxaliplatin, it causes neuropathy. We have a lot of experience in that with using FOLFOX in colon cancer. But Abraxane also causes the same thing. The main difference between those two drugs is that the neuropathy with Abraxane is reversible after 1 month. If you keep the drug off, usually the neuropathy does improve. As you could see by that, about 44% patient resumed therapy when the neuropathy was less than grade 2 in the patient who got a Abraxane arm. However, we know that with oxaliplatin, once you hit the neuropathy, those neuropathy takes very, very long time to get better, and we rarely ever get to re-challenge them with oxaliplatin. So subtle differences in terms of the toxicity profile. So the ultimate question is it FOLFIRINOX or Abraxane, nab-paclitaxel, and Gemzar in patients who are diagnosed with advanced pancreatic cancer? Obviously, the FOLFIRINOX was associated with better overall survival. Okay. However, if you look at the inclusion criteria, it was different. They had more of a stricter eligibility criteria, and patient with better performance status was allowed in the arm of FOLFIRINOX arm. Okay, but once again, the problem is that they had more GI toxicity, more febrile neutropenia. Okay, and they needed more support from the growth factor. Okay, and like I said, in U.S., most of us will start the regimen at dose reduction without the bolus of IFU and with dose reduction of irinotecan. On the other hand, the nab-paclitaxel and Gemzar seems like much better tolerated. But however, overall survival seems to be a little bit less than the FOLFIRINOX arm. Once again, I want to point out that the inclusion criteria was a little bit different. There are probably patients with a worse performance status that was enrolled in the Gemzar or Abraxane arm compared to the patients who were enrolled in FOLFIRINOX arm. However, once again, the key point of using combination is that a patient with ECOG of 2 or older patient tend to benefit from this drug. Okay, and some of the patients were excluded from the FOLFIRINOX arm. Remember, in the FOLFIRINOX arm, they had an age cutoff of 75. So what to do in practice? Well, I think in practice, we, at least in U.S., obviously I've used both of them in my practices, okay? And I think, both of the regimens have their places in treatment of advanced pancreatic cancer. And I think, depending on the patient's performance status, depending on patient's status with bilirubin or status with bile duct stents, I think we will choose one versus the other. But I think any of the choices is definitely reasonable in a first-line setting. But generally speaking, the patients who are a little bit older, who are a little more fragile, okay, who have other maybe comorbidity, I tend to use nab-paclitaxel and Gemzar. Patients who are younger, I tend to use FOLFIRINOX. So really it varies depending on patient's condition, and we need to select the appropriate patients for each chemotherapy regimen. So to summarize the first-line pancreatic cancer, so we know that Gemzar was approved a long time ago. Then came the drug called Gemzar and erlotinib, which was, once again, just really 2 weeks benefit, so nobody really uses that anymore. Then really there were a lot of negative studies, okay? And there was some data with using capecitabine or platinums and meta-analysis. But then recently we have more data using FOLFIRINOX and nab-paclitaxel, Abraxane plus Gemzar. And with those 2 regimens, we have a 1-year survival now, which is greater than 30%. 10 years ago, 1-year survival was less than 20%. Now we also see 2-year survival. If you look at the nab-paclitaxel and Gemzar arm, about 5%, I think 5 to 10%, those patients were living actually beyond 2 years. Okay, so now we're making some progress in first-line setting in pancreatic cancer. So very briefly, how about second-line therapies? Once you progress first-line, what do you do second-line? So here are some of the studies that's been done, that's been presented, which I will go over. The first one is called the RECAP study. This was a drug using the drug called ruxolitinib, okay, which is a JAK-STAT inhibitor, which I will go over a little bit. Then there was a new drug called MM398, which is a pegylated irinotecan, which was approved in U.S., I think it was last year, based on the Napoli study, which I will go over briefly. Before those 2 studies came out, probably the most commonly regimen we used second line was a regimen called FOLFOX, okay, similar. That was really based on the CONGRESO study. However, about 2 years ago, I think this data with the pancreatic study came out, which was a randomized phase 3 study. Patient randomized to FOLFOX versus 5-FU-leucovorin. Once again, it was a very small phase 3 study. It was about 54 patients in each arm, a patient who failed Gemzar alone. And the primary endpoint was PFS. They were looking at response rate and overall survival, secondary endpoint. In this study, there was no difference actually between the FOLFOX and the 5-FU-leucovorin. Okay, if you look at the graph here, the Kaplan-Meier PFS, as you could see, there was no no PFS benefit, and overall survival as well. Actually, the arm of 5-FU did better. Okay, so based on those 2 conflicting studies, really we don't know what the benefit of platinums is in second line. So typically, what we do is that if you give FOLFIRINOX first, then give Gemzar based a second line. If you gave paclitaxel first line, then you will give 5-FU based second line. That's how it typically works until we have now new data. And this is based on this drug called MM398, which is a pegylated irinotecan. The benefit of this compared to the regular irinotecan is that the PK value shows that there's extended circulation of this drug. Okay, the AUC seems to be much higher than the regular irinotecan. Okay, and the SMEO2016 shows much higher levels of SN38, which is the active metabolite in tumor compared to blood at 72 hours compared to irinotecan, telling us that this drug probably stays around the body a little bit longer, making it more effective. So based on this preclinical data, there's a trial conducted called the Napoli study, which is currently published, randomizing to the SMEO2016 single agent or SMEO2016 plus 5-FU-leucovorin or the standard arm of 5-FU-leucovorin, which they gave it as infusional. And the primary endpoint they looked at was overall survival, and they looked at PFS, response rate, and other endpoints as well. And what they found was that even though the SMEO2016 as a single agent did not have overall survival benefit, the combination of SMEO2016 plus 5-FU-leucovorin had an overall survival close to 2 months compared to 5-FU-leucovorin. So this is sort of the first large phase 3 study that has shown benefit of using a different agents in second-line setting. PFS, similar as well. The PFS almost doubled from 1.5 months to 3.1 months. If you look at the response rate, it's very important as well. The combination had a response rate of 16% compared to the 5-FU alone, which was only 1%. So in all three endpoints, the combination was positive. So the conclusion of the study was that this was a large multi-center international study. They met the primary endpoint of overall survival. There was a superior PFS response rate and tumor marker changes, including CA19-9. So therefore, based on those endpoints, this drug was approved in the U.S., currently available to use. And however, it does have side effects similar to irinotecan, including neutropenia, fatigue, diarrhea, and vomiting. Okay, so this drug is approved in patients who failed prior Gemzar-based therapy in second-line setting in combination with 5-FU, but unfortunately, as a single agent, there was no overall survival benefit. So single agents should not be given alone. So now, very briefly, last but not least, I'm going to go over very quickly some of those interesting trials that's currently going on, hopefully which will improve the outcome in pancreatic cancer. There are a couple of novel approaches to pancreatic cancer at this time, attacking the JAK pathway, which has to do with inflammation. Next is trying to develop novel approaches in drug delivery. Third is sort of exploring the desmoplasia and tumor environment. One of the reasons why we think that a lot of chemo don't work in pancreatic cancer is because of the microenvironment around the pancreas cancer that prevents the tumor penetration. And we think that's one of the things that's the reason why most of the drugs don't work in pancreatic cancer. Last but not least is immunotherapy. This is a very hot topic, as you know. A lot of trials going on in multiple GI tumors, including pancreatic cancer. But I must say, in pancreas cancer, immunotherapy has not really been up to the expectation compared to the other GI tumors. So very briefly, the JAK kinase inhibitor in cancer, generally speaking, is something that is active. We know that the mutations observed is the JAK mutations observed in several tumors, including pancreatic cancer. And we know that this IL-6 JAK-STAT pathway is actually upregulated in GI cancer, including pancreatic cancer. And there is a drug that actually targets that. There's a drug called ruxolitinib, which is currently FDA approved for myelofibrosis and polycythemia vera. So what they did was that they did a small, randomized sort of phase 2 study in second-line setting in patients who failed some chemotherapy. They were randomized to capecitabine plus placebo or capecitabine plus ruxolitinib. Okay, and interestingly, the endpoint is primary overall survival. And interestingly, what they found was that in the patient with elevated CRP, which is a sort of biomarker for inflammation, those patients actually had a benefit of adding ruxolitinib to capecitabine. There was an improvement over survival, and as you can see, if you look at the 6 months overall survival, it was 11% with CAPE alone versus 42%. And in terms of overall survival, there was about 1 month improvement overall survival in those settings. So based on this sort of promising phase 2 study, currently they're doing a phase 3 study with this drug in a second-line setting. Other thing that's interesting is that because it affects the inflammation pathway, patients who get this drug actually is gaining weight. One of the problems in pancreatic cancer is that they tend to lose weight. They become catabolic. They become very cachectic, most likely due to some of those hormones or cytokines that the tumor makes. But interestingly, a patient who gets the ruxolitinib on the study tends to gain weight, which in pancreatic cancer is a very good thing. So currently at this time, there are a lot of drugs out there trying to evaluate the inflammation pathway. I've sort of listed a couple of there. And right now, once again, there is a randomized phase 3 study going on in second-line setting, randomized to capecitabine plus ruxolitinib versus capecitabine alone. So very briefly on immunotherapy. So we know that the T-cell infiltration in GI malignancy is associated with better prognosis. It's been seen in gastric cancer, HCC, also been seen in pancreatic adenocarcinoma as well. There is some preclinical data that CD8 and the CD4 infiltrating lymphocytes improves the prognosis of the patient with pancreatic cancer, maybe telling us that the immunotherapy may be a good thing. However, to this date, the checkpoint inhibitors, that PD-1, the PD-L1s, that has been studied in the early phase 1s, none of them really show activity in pancreatic cancer. Even if they combine it with CTLA-4, really activity has not been seen, unlike other diseases. It is unclear why that's true, but currently that's unfortunately what's going on at this time. So what we have to do in pancreatic cancer is that we have to use different kind of combination to induce some of the better responses that we have seen similar to other diseases. And one of the sort of the highlights of ASCO was this year, I think, was like, for example, combining a BTK inhibitor. There's a preclinical data, if you combine the BTK inhibitor with pembrolizumab, such as the PD-1 inhibitor, there's a synergy actually. It makes it more sensitive to the PD-1 checkpoint inhibitor. And they did this study in a once again, very small study with 32 patients, and when they combined them, they saw a response rate of up to 10-15%. Okay, when in the pembro alone, really the response rate is about 0. Okay, so this is where we're going right now, trying to improve our outcome, not only with the checkpoint inhibitor, but with combination with some other chemotherapy, because we know that the checkpoint inhibitor by itself probably does not work in pancreatic cancer. So other studies that's been going on right now in the second-line study, so just very briefly, is a drug called glufosamide. This is a prodrug that acts like a Trojan horse, where basically it takes the cancers which needs sugar, glucose, takes up the glufosamide. Once it becomes incorporated into the tumor cell, it opens up and becomes a cytotoxic chemotherapy, thus destroying the tumor cell. So currently there's a phase 3 study going on right now, randomizing glufosamide with 5-FU alone, which is open nationally and in Asia and Europe as well. So here I just listed several trials that's going on right now in the first-line setting and second-line setting as well, clearly telling us that we're still very active. As you can see, there are a lot of trials trying to add some other drug on top of GEM plus paclitaxel or Brixane. The reason that that backbone was chosen is because of the toxicity profile. Okay, therefore, currently there are multiple trials going on right now. Hopefully some of them will finish accrual, and so hopefully we'll get some of the results of these trials in upcoming conferences. So to summarize my talk, so really there is some optimism in the treatment of the disease. Survival has clearly improved for metastatic disease compared to 10-20 years ago. Okay, and FOLFIRINOX could be considered standard in patient with good performance status and good organ function tests. And gemcitabine and nab-paclitaxel can also be a good standard as well in patient with PS of 0 to 2. Now in second-line setting, we think MM398 is a new option in second-line setting. There's always a question about, is there really a difference between MM398 and the regular irinotecan? But I don't think anybody knows that answer. Currently, unfortunately, we still do not have any biomarkers for this disease. So hopefully maybe the CRP is a biomarker in the second-line setting. So we're trying to get to that point at this moment. And like I mentioned, there are many new targets which are currently being evaluated. And ultimate goal, obviously, for any disease, including pancreatic cancer, is a personalized medicine. Thank you.